Yes.
Awesome. All right. Well, I think we are about as ready as we can get to kicking this thing off. I'm going to get my phone set up in a way that works because my computer is not working. Are you able to still hear me?
Yes, I can hear you.
Oh, okay. Well, this is David Sanchez, the chair for the Advisory Committee for Resilient Nevada, and I'm going to begin our meeting. I'm going to start with agenda item number 1. Today is April 9th, 2024. It is 10:06 a.m. And again, thank you for bearing with us while we figure out the technical stuff for getting this meeting started. And we will start with a roll call. See who is in attendance today. Joan, can you kick us off with that, please?
Jessica Barlow.
Good morning, everyone. Jessica Barlow, present.
Brittany Collins Jefferson.
Good morning, everyone. Brittany Collins, present.
Vilnitra Grady.
When I put in my, so when I put my user ID to the clinical system.
Good morning. No.
Yes.
Okay,
Yes.
just making sure. All right, thank you.
Ryan Gustafson.
Yes, Ryan's here.
Dr. Kamyar.
Present.
Carissa Loper. Catherine Loudon. Oop, I see her. I'll make her a presenter so she can speak up. Catherine Loudon. Elise Monroy.
I'm here.
Darcy Patterson.
Present.
Jamie Ross.
Present. Good morning.
David Sanchez.
Present. Thank you.
Ariana Saunders indicated she would not be here today. Cornelia Sheehan. Malika Tossin.
I am present.
Dr. Carla Wagner.
Present.
Winnie Winbush.
Present.
And Catherine Loudon, would you please indicate your presence?
Yes, thank you very much. I was having trouble connecting. I'm Catherine
Yes.
Loudon, and I am present. Thank you.
Okay, thank you very much. You have quorum.
Thank you, Joan. And good morning and welcome, everyone. We will now move to agenda item number 2, which is public comment number 1. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment telephonically, dial 775-321-6111. When prompted to provide the meeting ID, enter 846-416-202 pound. Please note that if you are joining by phone, press *6 to mute and unmute yourself, and press *9 to raise your hand. In consideration of others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on a matter discussed under this item until the matter is included on an agenda item on which action may be taken. Do we have anybody, excuse me, sorry, available for or interested in public comment? Joan, do you see anybody with their hand up or on the phone line?
I do not.
Okay. Well, we will move to the next agenda item. We have agenda item number 3, which is for possible action, review and approve the minutes from our March 12th, 2024 meeting. Did anybody get a chance to go over the minutes? Did anybody see any issues, or does anybody have a motion to approve the minutes from our last meeting?
This is Brittany Collins. I motion to approve.
Thank you, Brittany. Can we get a committee member to second that motion so that we can go forward with a vote to approve the minutes from our last meeting?
This is Jamie. I'll second.
Thank you, Jamie. We'll now take a vote to approve the minutes from our last meeting. All in favor, can I get an aye as in favor? Please unmute yourself and let us know if you're in favor.
Aye.
Aye.
Thank you. Do we have any opposed to approving the minutes from our last meeting? If we do, please unmute yourself and notify us with a nay. I hear no opposition. Do we have anybody that's going to abstain from voting in the approval of the minutes from our last meeting? Any abstentions? All right, we will approve the motion to approve our minutes from our last meeting. And we will move on with our meeting to agenda item number 4. In agenda item number 4, we will be receiving highlights from funded providers, and we'll be starting with Trac B and Rick. I believe we heard from him earlier. Rick, are you still online?
There we go. Unmuted myself here.
I gotcha.
Can you hear me, David?
Yes, I can, and the floor is yours.
All righty. I'm Rick Reich. I'm the executive director of Trac B Exchange, and we were awarded a sum of money to purchase syringes and sharps containers last July, and we went ahead with that. We have a large supply of syringes. We have a large supply of both small individual sharps containers, which hold anywhere from 15 to maybe 25 to 50 syringes, to some larger containers, which we can actually collect the smaller ones in. So that has been very, very beneficial to us. It's been a great relief, not struggling to try and provide syringes in the sizes that people would like. And it's given us a little bit of breathing room. We appreciate this and can't thank you enough. In terms of what we're seeing, we purchased approximately 500,000 syringes, which, if we were at our peak of distribution, which was about 55 to 60,000 syringes a month, we would obviously run out of those. But there has been a fairly significant change in the method of usage of opiates, and especially considering the fentanyl crisis going on. So we find more people are now starting to smoke their illicit substances, or at least attempt to. This doesn't guarantee that they're not going to overdose on this. In fact, there was a good paper put out of Vancouver back in 2021 that just discussed exactly this and the hazards and dangers of smoking. Not that injecting is any less dangerous, but some people have the impression that if you smoke the substance, that the chances of overdose are less, and that is not necessarily always true. So we've had a drop off a little bit. We're probably down now to right before the summer months is when we have our slower period. And so we're down to about between 25 and 30,000 syringes a month going out. And we're bringing in about 75 to 80% of that number is being brought back into being disposed of and destroyed. So what I would like to discuss just in a few minutes that I have is what we have seen in terms of usage by individuals that have come into our system as participants last year. And that is, how many times do they inject their substances during a given day? So in 2023, we had about 715 individuals come in that were regarded as new participants. They had not been there or claimed that they had not. And we're not an agency that goes about trying to really identify and get identifying information on individuals other than just a couple letters of their first name, couple letters of their last name, date of birth, and things like that we can put into a sequence of numbers just so that we have some way of identifying one from another on a given day. Obviously, there's lots of duplicates over a period of a year, but all of the first-time signups for participation go into one separate pile. So of that, we had people who injected between 1 and 3 times a day was pretty much the highest number. That's 61% of the people, or 432 individuals out of the 713. We had people who injected anywhere from 4 to 10 times. That was 164 people, and it was 23% of the mix of participants. More than 10 times a day, we had 28 individuals, and that was 4%. Less than daily was 62, and that came out at about 8%. And then we had another 27 that did not inject and were coming in for services, and that was about 4%. So it gives you an idea of just how often someone might use a clean syringe. And that's obviously one of our goals, is to make sure that people use a clean syringe each and every time they inject. In this particular case, what we have also seen is that we can then measure out how many days in between it takes for individuals to come back. And we have set sort of a limit on our average distribution of syringes, anywhere from 30 to 40 syringes each time they come in. The purpose in that is actually one of the under sort of lying principles of why we limit the amount of syringes, and that is we want the individual to come in for exposure. We want them to come in as often as we can get them in there to make them feel more comfortable, number one. Number two, to gain their trust, and three, to then be able to offer them services other than syringe and disposal. and that would be in terms of offering certain types of referrals for care, whether that be drug treatment, wound care, or just plain medical care. Also to offer testing for HIV, hepatitis, COVID, and so forth, and then to offer referrals based off of that for PEP and PrEP for HIV and for hepatitis treatment and wound care. So by offering syringes at a certain amount, rather than just handing over 200, 300, 400 syringes, you sort of get a person coming in more often. And in this case, we're trying for once a week to maybe 10 days on the outside. And that gives us roughly about anywhere from maybe about 45 to 52 times a year we're going to see that person. And that's probably more exposure than they're going to get in terms of law enforcement or emergency room or physicians or clinics, simply because they're needing those supplies and they keep coming in to get them. So it's one of the sort of underlying reasons that we offer syringes in the amount we do, and then turn around and promote services to them. Our vending services are set up the same way, and I'll close with that and just saying that right now we have our 3 machines running in Reno. We have 8 machines running in Las Vegas. We have 2 more machines to go out very soon in Reno. We have just secured funding also for the vending project to continue after a roughly 6 months lapse. And that will start up statewide, and we'll try to get more machines out into the communities. And again, our purpose there is to get people to come back over and over to utilize the machine. But since we're not there, what we will be doing is what's simply referred to as narrowcasting, where you cast information to an individual, not to a group. Broadcasting would be like TV. Narrowcasting is more of a singular message addressing just one individual at a time. And we can do that with various messages, which we'll be putting on all of the products within the vending system. So, and with that, I will take any questions if anyone has any. And that pretty much concludes what I would have to say today.
Thank you, Rick. Appreciate you taking the time to come and present for us and give us some information about what's been going on with Trac B. Do we have any committee members with any questions or comments for Rick while we have him? If you do, just unmute yourself and let us know who you are, and then I see a hand raised, but I can't tell who it is.
Dr. Kamiar can go ahead, and then I'll take my question second.
Thank you.
Thanks, Elise. Yeah, Farzad here. I guess a few questions. Are you guys able to track the number of folks who are actually given referrals or resources? Specifically, I'm looking for trying to see sort of an adoption rate of MOUD, so medication for opioid use disorder. Are they given clinic referrals to go to like methadone clinics that offer all 3 forms? And then do we have any data of the take-up rate, right? So retention rate in those programs. And then the other question would be that number of syringes. I was just looking into like New York State's policy on that, and they have like various factors that go into it. One of them is each individual person is assessed to see how many times they're injecting, what their syringe use needs are, and then they limit it at 600 at a time. I'm just wondering if that number that you guys have limited to takes into account those patient-specific factors, or is it just some internal limit that you all have? Just trying to get a sense of what sort of an evidence-based practice along these lines.
Sure. Let me address the last part first. We started off limiting the amount of syringes due to basically our supply. We could not furnish enough syringes because we just didn't have that many coming in. We didn't have enough funds and so forth. Obviously, now we have a little bit more security in terms of those funding issues, and we can offer more. One of the things we'll be doing in the next part of this year is actually packaging up separately syringes into a box of 40, which we will be distributing to individuals. And we did this through a company that we've been purchasing our syringes from, and asked that they rebox or repackage their materials into boxes of 40 rather than 100. Again, our purpose is to get people back in to the storefront, get them back to the vending machine to get more information and to have more exposure. We do understand that other areas will distribute more syringes. They usually, and when you talk to them anecdotally, will tell you that if you give out 100 or 200 syringes, that doesn't mean that that individual is going to utilize those. Rather, what in many cases will happen is that the individuals will circulate those syringes to others in one form or another, whether monetary value or for just sharing purposes to share clean syringes. Our population, we're really trying to convince and get them committed to using clean syringes each and every time, not cleaning the syringe, but simply destroying it, even to the point of breaking the tip off the syringe when they put it into the sharps container. In terms of referrals, as some of you know, Trac B had a program that was working within the emergency rooms in both Renown and UMC. We still are in UMC, but it's more now as a phone call, and then we would go over and help them out. But previously, for the last couple of years, we were in the institutions on a 24/7, 365-day a year calendar or schedule. And we were running fairly well in the amount of referrals that we took out of there and got into treatment, detox, and so forth. We do have numbers on that, and we can always provide those at some other time if you want. Just request them in an email, and I'll, put together what we've had previously. Right now, we are working with our linkage people outside, and most of our work now is going into outreach, trying to get people to use vending storefront activities to get their syringes. And we're going out and meeting people either in a static location where we go to that same place every week, same time, same vehicle, park, distribute product, or we're going to selective fluid sort of situations where it might be a tunnel that someone or some people are staying at, or it might be a lot, or it might be the back of a empty building or wherever. And we go to those as we find them, and then we try to sort of direct people to the vending, to the storefront, or try and set up more regular basis to that area. However, in most of those cases, we find that law enforcement at one point or another will come into play, and the activities will cease simply because the people will be moved on. They will be dispersed, and that location will be, for lack of a different term, cleaned out, and everyone sent on their way. So, but I have nothing I can give you right now off the top of my head, mainly because I'm sitting in St. Joseph, Arizona, in my car on traveling back to Las Vegas. I've been gone for about a week. So, but email me and I'd be glad to supply you with what I can. I hope that answers your question.
Thank you, Rick.
So this is Elise Monroy for the record. So I have actually a question for the state on allowability of funding. But the first thing I'd like to get on the record is I would love to see Trac B be able to give people that are using injection, like using needles to inject, to be able to give them however many syringes they need at any time. And maybe if there was a way that we could utilize ACRN funding to find other ways to incentivize people or encourage people to come back to the center, that would be great. I'm sure that there's a way that we can do both. So I'd be curious to know, and I know there's other people on this call much smarter than me on harm reduction, but if we could use this funding to give people everything they need when they're there, and then find other ways to encourage them to come back into the center. My question is to the state. I don't know if Dawn is on, and she might not even know the answer to this. But I really appreciated, Rick, hearing that there's been a change in consumption with more people smoking. So I'm curious to know, Dawn, do any of the settlements specifically prohibit dollars being used to buy safe smoking things? So is there any prohibition on any of the settlement funds for that? And I know that there's a lot of settlements and they all have different kind of parameters, but could we buy safe smoking?
Elise, Dawn isn't here. This is Joan.
Oh, okay.
So Dawn is not here today,
That
but we do have,
the smoking,
go ahead,
the
Joan.
smoking is considered drug paraphernalia under MIs.
Okay,
Smoking
so that's good. So that's good to know from a policy perspective. But so then do the grant funds prohibit the purchase of anything that's defined as drug paraphernalia in NRS?
Yes, they
do. Okay.
NRS was specific about that.
Okay. All right. Thank you.
But again, I thank you for your question, Elise, and thank you for the clarification, Joan. We do have Vanessa Diaz with us today that is filling in for Dawn as best she can. So I think that it sounds like it's at least something to look into for the committee to find out what ways can the ACRN, as they make recommendations to the director's office, find the ways and means to support Trac B and the opportunities that we see with them. I have Carla Wagner. Did you also have your hand up for question, comment?
I did. This is Carla Wagner. I did, but I think Elise basically answered it. But since you're letting me talk, I will. I will ask Rick. This is Carla Wagner. I was just wondering, if you had more money, could you give people more syringes? Would you give people more syringes?
Yes, but again, I go back to trying to establish that relationship with the individuals. The problem I see sometimes with giving out larger quantities is that they get lost, they get stolen, and you have to also look at how the individual is going to carry all of this. And so it's one of the reasons we went for our own boxing, so that we could actually have it where it's fairly easy to carry and not real obvious. We do the same thing with the packaging that we put supplies into. We don't just distribute syringes. I mean, we distribute a lot of different types of incentives to individuals when they come in. So if you have an individual, let's just say, that comes in and wants to pick up some syringes and they are dropping and disposing of syringes, we'll offer them some type of incentive, anything from clothing, hats, hygiene kits, MREs in terms of food, snacks, water. We, for the most part, also supply on any basis that when an individual comes in, if they want a snack or if they want to fill up a water bottle or whatever, we have water available for them to actually fill up rechargeable bottles and so forth. The reason again for the amount of syringes is to get those individuals in there more often. And also, even though we cannot buy paraphernalia items with grant dollars, we can with our own private dollars buy things such as foil, hookah pipe tips, straws, things like that. Now, when those individuals take those items from us, they are then, if they use them, it is then considered paraphernalia. And so, we want them to get rid of that as fast as they can. So it's not like give them a supply of, a huge box of foils, rather give them a small supply of probably 10 foils at a time, knowing that they can also wipe these off and wash them and clean them. But that way they can dispose of them more quickly. This is something that's going on in Washington State, for instance, which still has some laws against syringes, and they don't bother to collect and dispose of syringes. Their needle exchange programs, for the most part, they tell people just get rid of your syringes. So we, on the other hand, are trying to get them to bring them back in, dispose of them. And so it becomes a cycle. Get new syringes, drop off your old, pick up supplies. And thus you have more communication and more of a chance of getting people referred into treatment. But we can always use more money and resources to buy supplies. That's like how can I describe it? It's just a constant. We're always trying to find something and finding a way to get it.
All right. Thanks for your response, Rick. And thank you again for taking the time to come to this committee meeting today to fill us in and give us a picture of what's going on with Trac B. Again, if any committee member has any further questions or needs clarification from Rick, the best way to go about it is to email him. And to do that, if you don't have availability to his contact information, you can reach out to our state staff, being Joan and Dawn, and request that information, and then we can get you connected. We will now be moving on, continuing agenda item number 4, and we will be hearing from Living Free Health and Fitness and Shelly. I don't want to mess it up. Not sure how to say it.
Poerio, Shelly Poerio, Living Free
Thank
Health.
you,
Hi, thank you, David. So I guess you just kind of want me to talk about what we're doing. We applied for a grant under the Resilient Nevada, and the grant that I wrote was focused on providing housing and treatment for frontier area residents. That would be like, we're in Pahrump, and we're based in Pahrump, and we're a 501c3. And we do get referrals from time to time from Las Vegas, but the need that I really saw was that that people in areas like Tonopah, Round Mountain, Amargosa, Beatty, et cetera, there are not resources available for them in those areas and beyond. And so the grant was written to be able to help them. And of course, they have to have an opioid use disorder and or some exposure to opioids in a way which is misuse. So so thus far, so we received the award, I believe, in May, or at the very end of May, and we had 2 months to add a house. So we added a transitional living house in 2 months, and that opened on August the 1st. And at that point, we have 8 beds available for this purpose, and 6 of them are funded by the grant, and other things that are funded by the grant are mileage for us to go and pick people up, say from Tonopah or Round Mountain. And then also welcome baskets. We call them welcome baskets, but obviously if people are coming from jail or from the streets or something, there is a need for some basic hygiene materials, linens and things like that. We do have a good number of donations that we receive just as a 501, so we generally don't need to buy people clothes, but underwear, socks, sports bras, things like that, feminine hygiene needs, etc. So those things will go into a welcome basket. At this point, we have, I'm looking at my notes here, we have, we just admitted someone yesterday, so I should step back. We have a men's house, we have men's housing, women's housing, and a women and children's program. So, and women and children and or pregnant women. And so right now we have one who started with us under the grant, but for problems with her parenting skills, I'll say, she was discharged from housing, but she continues to remain in program with us, but she's not in the housing. We added a woman yesterday from Tonopah, and she is going into the Women and Children's program. We have one woman who's been continuous with us since the summer, 2 other men who've been continuous with us. We've had 1 successful completion, and another gentleman from Beatty. We'd actually already had him from drug court for about 6 months, and I never really moved him onto the grant because I felt like he was already covered under a different grant. So I didn't want things to kind of get too confusing. So we've had a total of 11 patients in 7 months. Of course, we've had some failures as well. We've had people who we had to discharge for behavioral reasons or who absconded. But our status right now is that we have 1, 2, 3, 4, 5 active on the grant. And Joan, was there more information that you wanted me to share? Kind of like what our challenges have been? Maybe
Shelly,
that's it.
Would you share about the cafe and the gym?
Oh, yeah, absolutely. Oh, yeah, totally forgot about, that's crazy. I forgot about that. So one of the things that we've done at Living Free is I had this concept of a therapeutic workplace. So one of the things, so what we offer is we offer level 2.1 and level 1.0 outpatient treatment and transitional housing. That's all SAFTA credentialed. And then, you know, part of the thinking is, well, how do you get people to stay clean and sober over the long run and after they leave treatment? And some of that is rehabilitating them or habilitating them with job skills and knowledge. So we have Living Free Cafe, which is staffed almost Living Free Cafe and Living Free Gym. These are real businesses. They're doing business as businesses under Living Free Health and Fitness, the nonprofit, the mothership, if you will. But we hire people who are in recovery primarily. We have a couple who are not in recovery, but have been affected by addiction, like drunken husbands and domestic violence kinds of things. So what we teach in the therapeutic workplaces is that we give them the job skills, teach them job skills and appropriate aptitudes and knowledge base and that sort of thing, so that they're prepared to continue and move on. And of course, our workplaces are clean and sober, which are important because lots of workplaces are not clean and sober, and people get tempted and may relapse. So Living Free Cafe employs 8, and the gym right now employs 6.
Okay. Thank you, Shelly, for giving us a brief overview of how the funds from the opioid litigation funds or funding is supporting the program that you have. Do we have any questions or comments from committee members for Shelly? Again, I'm kind of having a hard time working this meeting and being able to see whose hands are up. If there are any questions or comments from the committee members, if you could unmute yourself and let us know who you are, I would appreciate it.
My name is Connie, certified peer and supervisor at the Empowered program. I just have a quick question for Shelly. I wanted to ask what qualifies the pregnant women? What makes them eligible for your program? And also, how many beds do you have available there?
So they have to have some substance use disorder. We are Medicaid provider type 17, subspecialty 215. So their primary diagnosis has to be a substance use disorder. Under the grant, they must have either an opioid use disorder or, you know, some opioid misuse.
Okay.
But the house is 5 beds for 5 women. And up to 2 children each, and the children need to be 8 years or under. We've expanded our regular women's housing, and so we have made the determination if someone is in the first trimester of pregnancy and the house is full, the women's house is full at Kiowa Street, that we could put a pregnant women in one of the other women's houses and matriculate them through. I hope that answered.
Yes, you did. Thank you so much. I appreciate it.
You're welcome.
Thank you, Quinny. Do we have anybody else with a question or comment from the committee for Shelly? Living Free Health and Fitness. I don't think I'm seeing anybody else with a hand up. If there are any follow-ups or anybody has a question or wants to get the contact information for Living Free Health and Fitness, please reach out to our state staff and we will get you connected. Thank you again, Shelly, for coming today and presenting to us.
Thank you for the opportunity.
We will move forward now on agenda item number 4, moving to the Empowered program with Dr. Andria Peterson and Rachel Mack. Are you available?
I am. We're ready. Can you hear me?
Yes, we can.
Okay, I'm gonna share some slides. And okay. Sorry, I'm just having a hard time starting it from. Let's see. Pull this up again. Just a second.
No problem at all. It's been a day of technical
You know,
difficulties everywhere.
So I frequently struggle with Teams. So, okay. Can you see? Okay, are we good now? Can you see that?
Looks good. It's on present mode only. It looks really good.
Perfect. Okay, and everybody can hear me? All right, let's go for this. So thank you for the opportunity to be able to present this to this group today. I'm really excited to be able to tell everybody a little bit about the Empowered program and the work that you're doing, that we're doing. Today, you'll hear from me, and I serve as Executive Director, and then you'll hear from our Associate Director, Rachel Mack. And then we're really fortunate to have Amani Wilson, who is a prior client who has been discharged with us, to be able to share a little bit about her experience. So as we head into this, I want to stress that all of the faces that you're seeing in these slides are actual clients of the program. So I think a lot of times, you know, when you're doing the work that this committee is doing, you don't always get the opportunity to be able to see an actual face that's benefiting from the services. So when you see any of the infant faces or any of the other faces here, these are actual clients participating in services. So as we talk a little bit about the Empowered program today, I see lots of faces on here that are friends of the program and who are great supporters of the program. So, you know, we talk about pregnancy a lot. And so I think it's really important as we start this conversation to just discuss that pregnancy is a time for change, and pregnancy offers a really unique opportunity to be able to make an intervention where individuals are more willing to seek care and treatment and remain in care and treatment and to have that sustained recovery. So pregnancy is a really important time to be able to offer services and support services. So when we talk about pregnancy and we talk about opioid use disorder, it's really important to mention that drug-induced death is the leading cause of death for reproductive age women in the US. As we talk about this, it's also important to be able to understand that age range, which is 15 to 45. So I'm going to say it again, drug-induced death is the leading cause of death for reproductive age women in the US. Now, the accompanying side effect that or associated effect that can occur with that in our infants is something known as neonatal abstinence syndrome. And essentially that's withdrawal that's seen in the infants, and that does result from sudden discontinuation of fetal exposure to substances that were either used or abused during pregnancy, with approximately 82% of NAS births being funded by Medicaid. Sometimes you guys might hear the term NOWS. NOWS is just a very specific form of neonatal abstinence syndrome that occurs due to opioids. It's neonatal opioid withdrawal syndrome. But in Nevada, we typically just use the term neonatal abstinence syndrome because we see a lot of times poly substance exposure. The other really important thing to take away from this slide is that this is preventable. So it's the leading cause of death, and this is absolutely preventable. So we talked a little bit about the national picture, and we know that, that we are in the midst of an opioid epidemic and that nationally the numbers are high, but what does this look closer to Nevada and closer to home? And so this data was made available through the Maternal Mortality Review Committee, and this presents an exact, it's consistent with what we're seeing nationally, and that is that the #1 cause of death for pregnancy-associated deaths in Nevada is overdose. So again, something that's highly preventable. And as we head in to talk about the program, I also wanted to mention that postpartum period. If you look all the way to the right on these slides, you're going to see that really, really big black bar. And basically this represents the overdose risk during the postpartum period, which is actually highest days 43 to 365 after giving birth. So when we talk about, support services that need to be in place for individuals experiencing opioid use disorders and substance use disorders during that pregnant time period, it's really, really important that those services are available not only during pregnancy, but that they continue during the postpartum period, which often a lot of times is discussed as the 4th trimester. So that leads us to what we're talking about today and what's being done to mitigate the effects of maternal opioid use disorder and neonatal abstinence syndrome. And the solution that we have is Empowered. And again, I want you to take a minute to look at these faces and to look at, our program participants and then these babies. Empowered supports pregnant and postpartum individuals who use or have a history of using opioids for any reason, with a tailored, person-centered approach focused on the 4 dimensions of recovery that's designed to empower individuals to be prepared for the birth of their infants and to thrive as a caregiver. So as you look at, these faces, all of these infants were at risk for neonatal abstinence syndrome. So it's really, really important to put that into context. I want to talk briefly just about those 4 dimensions of recovery, because everything that we do at Empowered is evidence-based, and everything that we do really tries to focus on these 4 different dimensions, which include community, health, home, and purpose. So it's really important to have those strong social networks. It's important for our clients to be able to learn how to make, informed, healthy choices. It's important to have that stable and safe place to live, and equally important to have that meaningful daily activities and independence, income, and resources to participate in society. When we talk about the core services offered to Empower, these are things that are available for all clients that are with us. We do that through personalized care plans. We do that in a pretty unique model here at the Empowered program, and that's by addressing the most urgent need. So when a client initially comes to us, we ask them what their most urgent need is. We help them to address that. We build trust, and then we develop that, tailored patient-centered treatment plan. And we help them to access resources that address the social determinants of health. We provide counseling services. Those are in the form of individual and group therapy. We provide access to peer support, and we're going to talk about that in a minute. And then health education. And health education is an important part of the program because that helps promote that overall wellness, which has been formed has been found to prevent against future relapse. So again, I'm going to turn the time over to Rachel Mack, and I'll progress the slides. But I just want to again thank everyone on the committee for the opportunity to present and for your time, because we can't do the work that we do without the work of this committee. So this committee is very much a part of the program and the success that we've had through the program. Rachel, are you ready?
Awesome. Yep, I'm ready. Thank you. So with the FRN funds, we've been able to really expand our services as it pertains to peer support. I've had the pleasure of being with the program since 2018 as a social work student, and since then to now, I'm continually reminded how important peer support is for this target population. So thankfully, this fund has really helped us expand on that. So peer support specialists have been provided with the opportunity of working at the top of their practice through the activities that we offer. So individual sessions, group sessions. What we've been able to add is accompaniment, home visitation, and care navigation. So really that's a client having the chance to work with a peer with that lived experience and helping them navigate community resources. Implementation of stage-based activities. This here has been amazing. Like Andria mentioned, that additional support is really needed during that postpartum period. So separating our clients within the stages of pregnancy, 0 to 12 months and 12 to 24 months postpartum, we've been able to enhance core services by providing stage-based interventions that group clients together. So again, they're within their peer group, and the education that they're being provided is based on where they're at that stage. So I'll be able to talk a little bit more about that in the next slide. So, excuse me, stage-based community building activities. Stage-based peer support groups are what we're offering, as well as stage-based sober social activities. So the support groups increase the relevance of peer-to-peer experiences, which we again know is very, very important. And then the sober socials are increase the development of supportive relationships, yoga, safe sleep and car seat safety, healthy eating. What's really cool about the sober social events is that with the stage-based groups, the clients are all within that kind of same journey of their life as it pertains to pregnancy or postpartum. So they're building those relationships, they're having those conversations, and increasing their healthy support system, as well as learning more about themselves socially, and then the other individuals that are in the program. So it's really awesome to have those sober social activities that are focused on the client at what stage that they're in. Stage-based health education. I'm really thankful that we have the opportunity to, first off, even provide education to our clients. A lot of them don't have the opportunity or access to the education that we've been able to provide them. So education developed specific to the stages. Pregnancy, we focus on prenatal care, medications for opioid use disorder, and NAS mitigation. So a lot of that curriculum a lot of that education is about how it affects the substances that they're using and or how to sustain recovery, and how that is beneficial to their pregnancy stage and how that benefits the infant's outcomes. 0 to 12 months postpartum focuses on addressing barriers, triggers, parenting skills, and sustained recovery. So again, big emphasis on that sustained recovery and how to support them through that as they're bringing their baby home and or working through whatever challenges they might be dealing with. A lot of our clients do have CPS involvement and engagement, so that's another area that we're supporting and advocating for them during that stage. So that parenting skills and education is really important. And 12 to 24 months postpartum, focus on building resiliency. We know for all our clients, reaching resiliency is different for all of them, whether that's employment, education. Some clients are working towards disability or different resources to connect with other family support so that they have more support within their family. Ongoing social support, so again, reconnecting life skills and self-empowerment. So we really do help clients, that resiliency piece, we help them understand what that looks like for them and how we can support them through that. Sometimes that's connecting them to other resources in the community. We have a lot of clients that are attending Celebrate Recovery as they have time for it, different NA meetings, different things like that to support their ongoing social support. And again, educating them on how important support is for maintaining sobriety. So those 4 dimensions of recovery, we've been able to really, really emphasize within our program and the curriculum that we're providing our clients. So again, community, health, home, and purpose, building a sense of community, establishing strong relationships when conducted in a group setting. This is so beautiful. I wish you all could be a fly on the wall when we do our group settings and events with our clients. It really is beautiful to see them feeling that sense of community, wanting to be here, wanting to be engaged, and wanting to honestly be here as much as they can, so that they can have that healthy support around them in a healthy environment. Educates and empowers clients on how to better manage their overall health and recovery for them and their family, educates clients on how to create safer home environments to prevent relapse. So a big part of our peers doing home visiting is touching on how to better support their home environment, and what tools can be used and what resources that can be used to create that environment, especially if they have multiple children and other individuals living in their household. Opportunities focus on mindfulness, stress management, educational, vocational training, job readiness, and the value of their story promotes a sense of purpose. So giving clients that motivation and encouragement to help them understand that we do care about their story. We are thankful to be a part of their journey. And we want them to know that your story is helping the next person. And that's what's really nice about peer support, clients being able to see that role model, seeing that it's possible, and seeing that one day I could do this too if I want to, or even just reaching long-term sobriety and having my children and maintaining a full-time job, knowing that there's purpose from their life, and that it does help other individuals. Empower Snapshot. So this is a group picture of our clients during one of the events we had. So you can see a lot of beautiful faces. 75 active clients participating in FRN activities. Again, so we have the stage-based services, so kind of separating it throughout the client's continuum of our program. Pregnant clients, 15, 0 to 12 months postpartum, 44, 12 to 24 months postpartum, 9. We do have some clients that we have supported past that 24-month period, but again, it's working on safe transition and discharge planning. So there's 7 clients within that category. Interventions that these clients are receiving: case management, 376 sessions, and peer support, 259. Supports a network of 65 community partners. Just to highlight on that case management piece, that is a high number, but we're always providing our clients, like Andria mentioned, from intake, figuring out what their most urgent need is throughout their full continuum of them working with our program. They have access to care coordination and case management. So we're constantly connecting our clients to resources based on their needs. Their situations are changing. Sometimes they approach different crises or whatever it might be. We're constantly providing them with the intervention of case management to support them from recovery to stabilization to resilience.
Thank you. And with that, Amani, are you with us? There we go. I think she needs to unmute maybe.
Does it give her the option to? Because I only had the chance once our presentation started.
Can you hear me?
Yes.
I am working on it now.
Okay.
Joan?
Thank you.
Sorry about that, Amani.
Thank you very much.
Oh, there we go.
Thank you very much. My name is Amani Wilson, and I had joined Empowered back in May of 2021. It was a very hard time in my life. I was homeless, I was pregnant, and I really didn't have any support in my journey, and I was wanting to get clean. A lot of the places I went to, I was looked down upon for being pregnant and still using substances, even going to treatment centers that are supposed to help people with substance abuse disorders. When I found out about Empowered, it was through a friend. And when I originally started, we only, I think it was only like maybe 3 people in a small office. And what I utilized most was Miss Quinny. She was my go-to. The peer support definitely is what I needed for support, that sense of community, having someone to talk to when I was going through hard times, just having someone to reach out to when I needed some kind of wisdom and advice and certain things to do and how to carry myself and how to have a safe home. And Miss Quinny was always there to answer the phone for me, which is amazing, which was amazing. I also wanted to piggyback when Miss Rachel was speaking about the community and feeling like you're a part of a community. What they did have as well was, and we still do, is a Thursday group and it's a virtual Zoom link. And when I was attending those meetings, sometimes I wouldn't want to go, and then I would end up going and feel so empowered, knowing that there are other women who are going through literally the same exact thing that I was going through at that time. I know that having just a group of women who were just in the same sense, we're all trying to stay clean in our recovery journey. We were all dealing with other motherly issues on top of that. So just learning how to balance that, hearing other advice from other ladies who are literally going through the same thing you're going through was definitely amazing. It feels like a family. And that's one thing I liked. And that was the first bit of support that I had to actually help me feel like, hey, you can do this. I did want to say that I know that Empower really is great with navigating and advocating. I know that they definitely do a great job listening to your needs and prioritizing the order of your emergent needs. So I know when I came into the program, my emergent need was substance use disorder, and I utilized the therapy services offered by our therapist. And that helped me get to where I am today. I took the skills that she gave me and I actually applied them, and they worked and helped me to build resiliency. I know that also at one point, not when I first joined the program, but towards the middle of my time in the program, I was having troubles with housing. I was just so focused on not using that I wasn't working at the time because I was just worried about my journey of recovery. So I didn't have any money, and so rent needs to be paid. And so our program care manager, she was amazing with linking me to to resources in our community. And I didn't even know that my own health insurance provided resources. And so they were able to cover my rent. I know that being busy is a key part in recovery, staying active, just doing things. Because a lot of the times, your idle time is not our best friend in that sense. And so there's always something to do here at Empowered. You can always engage yourself. I was doing 2 therapy sessions. One thing I do love also, when you're in recovery, sometimes you get tired of hearing about recovery. And sometimes you just want to do something for yourself. So what Empowered offers is mental health group. And so you're not going to a group where you're talking about substance use, but you're talking about your mental health. And I feel like mental health is the key issue to help you to stop using substances once you can gauge that. And so they have those every Wednesday, and those classes are amazing. Right now, they're talking about anger. So it's just all the little things that help you stay resilient in your recovery. I know that so speaking about the stage base that we have, they've done car seat safety. So of course, car seat safety is going to be different than for a baby than it is for a toddler. And learning, and I didn't really know how, I have a 7-year-old and I have a 2-year-old. And so it's a gap. And I didn't realize how many things have changed and the ins and outs. And one of our peers, Sam, she's certified in car seat safety, and it brought light to my world. So having that, we also have done like STD classes. So that was a very big eye opener, especially in the world of substance use disorders. And then we've had dentists come down to teach us how to help our children brush their teeth, which was absolutely amazing. And that was also a stage-based thing that we've done as well. And right now they're doing yoga, which is stage-based, and I was able to do it. It was so much fun. You're able to bring your child and just stretch. And when I did it, we were out in the park. So it's nice. It's not what I love is that we're not everything is done in office. So we are able to go to UNR, do a cooking class for our children of our age, or the children that we have for our age bracket. So it was nice learning how to cook. I would call it vegan, but a vegetarian enchilada. And I usually don't eat squash, and I tore it up that day. It was delicious. So just projects like that, things that they do, it's absolutely amazing. I know I probably wouldn't be where I'm at today if I did not have the support of Empowered being there right by my side, educating me, advocating for me. And it's funny how we mentioned that they do help with CPS, and I did have a CPS issue, and having the support from Empowered, it was open closed, and that was truly a blessing. So Empowered is truly a wonderful program, and thank you guys for your support.
Thank you, Amani. So with that, sorry, we may have gone a little bit over, but with that, we'll open it up for questions.
Yes, thank you, Andrea, Rachel, and Amani. Excellent presentation. Do we have any questions or comments from the committee members? I have Catherine Loudon.
I just wanted to say thank you for sharing all about that and about the program. It looks absolutely wonderful, and such a great to hear of this resource that's available.
Thank you. We do keep criteria very open. So criteria for Empowered in general is opioid and or stimulant use disorder. If anyone is pregnant or in that postpartum period, that's it. We don't have any other restrictions. We're expanding in Northern Nevada, so those Northern Nevada friends, watch for information, but we're going to start taking clients hopefully next week, but we're just really grateful for the support of this community.
Awesome. Thank you, Catherine, for your question, comment, and yes, again, really appreciate hearing from you, and thank you, Amani, for showing up and sharing about your experience with us and how Empowered has helped you out. It's good to hear. Really brightened my day.
Thank you for having me.
It looks like Elise might have. I see her face up there.
I do. So thank you. So, Amani, thank you for sharing your story. I also don't like squash, so any recommendations on how to prepare it, I would take, because it's really good for you. So I have a question for either Rachel or Andria. So yesterday I was watching the interim health committee hearing, and the local health districts were talking about a pretty staggering increase in congenital syphilis. So I'm not sure if it was Washoe County numbers or statewide, but there has been since 2019 a 330% increase in the number of congenital syphilis cases in Nevada. We know for a really long time Nevada has been an unfortunate leader in the pack of congenital syphilis cases. And I see that you guys serve pregnant clients. So can you talk about how you're working on this issue? And then I would just like to flag for state staff. I know Dawn's not here. Joan, you might know. I would be curious to know if internally DHHS is working with public health folks to understand how opioid settlement dollars can be used for congenital syphilis. We know that one of the things they see in these cases of congenital syphilis is comorbidity with drug use. So just kind of wanted to flag that, but I'd love to know how you guys are experiencing congenital syphilis and how it's impacting your clients.
Absolutely. I'd love to take that question. I'm actually on the case review team for the Nevada Congenital Syphilis review board. And so I've had the opportunity to participate and review cases for the state. So yes, here in our program, we absolutely see individuals that are diagnosed with syphilis. Actually, the intake we had last week, who was pregnant, was reinfected with syphilis. So we're working on getting her connected for treatment. And so we thankfully have been able to really partner with Southern Nevada Health District and really work heavily with their case management team that they have specifically for syphilis, helping their clients get to those appointments, whatever barriers that might come up. We're working really with them to make sure clients are getting that treatment during their pregnancy. That we do see a lot of that. We've seen more and more of it. At least I'll just let you know, we have seen more and more of clients that they either have syphilis or again have been reinfected and have had it in a previous pregnancy. So yeah, we thankfully here in Clark County, we have that support with the health district. But again, as Amani mentioned, that education piece is so important. So working with them, providing our clients with education on family planning and safety and harm reduction, giving clients that education is, I think, really, really important to help reduce that. But again, we have the opportunity here. What we're learning in Northern Nevada is a little bit different when it comes to having the access to support screening and treatment for syphilis. And so thankfully we do have that support here with the Southern Nevada Health District. But yeah, we're absolutely seeing an increase. Only thing I'd like to mention is that for this population, like you mentioned, there is a lot of comorbidity between substance use and STIs. And so we have seen that. I think of, just to emphasize again, education piece is really, really huge, as well as that care coordination and supporting clients through that. It is so hard, I think, for them to do it on their own. From what clients have shared and when I'm learning about the process myself, say a client might have signs or symptoms, okay, then to get go make an appointment to get tested or find a clinic that is able to do walk-in, or it takes transportation to get there, and then going to the next place that can maybe provide the treatment. And again, those treatments are more than one appointment. And so getting all that done with all the other barriers that they have in their day-to-day life, the education and that case management to support them through that goes a long, long, long way. For them to see it through, and again, complete that treatment prior to pregnancy, because it's very prior to delivery, because it really is it's a time sensitive diagnosis. And so understanding that, and what's really nice with our clients, with the peer support, we're able to really build a great rapport with our clients, where they are coming to us and asking and wanting to know, okay, where can I go get treated? Or, you know what, my partner's doing this, I think I need to go get treated. Where should I go? And just being open to having those questions. They know we pass no judgment. Like I mentioned, the client that we had intake last week, pregnant, this is actually her 15th pregnancy, 40 years old, syphilis, chlamydia, and gonorrhea. As well as legally blind. So like so many challenges, right? Already from that, homeless, living in a motel. She's only lived here for 3 weeks. So navigating community resources for someone that's not even a part of this community, is already hard. But then those other social determinants of health that impact her being able to be compliant and take care of the things that she was actually interested in going to get tested and getting treated. So being able to support our clients through that and building that trust and rapport really makes a difference, so that they can, get the help that they need and the help that they want to get.
I will
Hopefully
put in
that answered your question, Elise.
I will put in a quick plug for the Southern Nevada Health District as well, because they recently received some grant funds, and I'm not sure where those funds came from, but they wanted to do some different listening sessions to be able to generate an ad awareness campaign towards that. And so they were able to host a listening session with Empowered, and then we were able to help them host a listening session with West Care. And I know that both sessions were just, clients were really gracious with sharing their stories and their experiences, right, and really appreciating being part of that process. And we're very, just open with their personal stories. And so I don't know what they developed out of that or what came out of that, but that was something that I know that our clients really appreciated being part of the solution. So,
yeah.
Well, thank you for that. And yes, Rachel, good to know that you guys have great partnerships with SNHD, but there might be a gap in the North is kind of what I heard. I also appreciate the reminder that these like addressing these issues is not as simple as like just going to Empowered and just talking to Andria or Rachel, because you guys are amazing. It's like actually really complex to treat congenital syphilis. So I appreciate the reminder in that. And then again, just to flag for the state, I would love to know more at a future meeting about how ACRN funds might be used to support congenital syphilis work, especially if there's gaps for screening and testing in the North.
Great, thank you.
Awesome. Thank you for your question, Elise, and thank you so much for presenting today, Andria and Rachel, and for bringing and sharing your story with us, Amani. We appreciate your time, and again, we have our thanks.
Great, thank you.
Oh, I have one more question before we let you go. I have Dr. Kamiar.
Hey, Farzad here. Actually, not a question, more of a comment. Elise, you'd asked. at least basically across the board, I think we can say the majority of cases are the result of sort of individual or systems based, right? Obstacles, deficiencies. We actually in Southern Nevada, I'm not exactly sure on Northern Nevada, but in Southern Nevada, if you get prenatal care, there's a really good chance that you're going to sort of hopefully identify and treat effectively, right? So any program that is hooking patients up or linking patients to just the simple act of prenatal care will probably help us decrease those rates by leaps and bounds. In the North, I think that's one of the main goals, especially with the Empowered program. So that alone, right? That alone, not doing really anything fancy or complex. It's prenatal care. Again, I'll speak to the South that our OBs do a really good job at screening for, assessing, treating, but hopefully the same is true in the North.
Excellent. Thank you, Dr.
Oh,
Kemner.
sorry. And along those lines, probably one of the most, if not the most, individual level barrier. I'm going to throw in two. Would be lack of insurance, but substance use, right? Just all the stigma with that, and we know that uptake rates of prenatal care for various reasons aren't the greatest, unfortunately.
Again, thank you for the clarification and giving us a little bit of insight there, Dr. Kemner. I appreciate it. All right, well, if we have any further questions for Empowered, we will have state staff give you the information to get a hold of them. And thank you again for presenting today. All right, we're going to move on with our meeting to agenda item number 5. And for this one, we'll have a presentation or an overview of a potential wastewater analysis project by Ben Rendo from Sturgis Bioanalytics and Chase Whitmore from Argentum Partners. Ben, Chase, are you ready for your time?
Yes, yes. Thank you guys very much for having us. Excuse me. My name is John Sandy. I'm a partner with Argentum Partners, filling in for Chase this morning. He had to run up to a meeting, so I'm the second stringer here. But it is with great pleasure today that I get to introduce you to Mr. Ben Rendo. He's the founder of Sturgis Bioanalytics, an innovative wastewater testing company that's really at the forefront of public health and safety technology. Sturgis specializes in groundbreaking approach to combating the substance abuse crisis that we are encountering, and that it's a concern that deeply affects all our communities here in Nevada. Mr. Rendo and his team at Sturgis have developed a state-of-the-art method for detecting opioid usage and other drugs through advanced wastewater testing. This technique not only identifies the presence of opioids, but also quantifies their level, allowing for precise understanding of drug use patterns in specific areas. This data is crucial as it provides actionable insights, enabling targeted interventions and informed policymaking to combat the drug epidemic effectively. Sturgis's approach is non-invasive as it focuses on community-level analysis rather than individual testing. And by partnering with Sturgis, the state of Nevada can leverage this innovative technology to gather vital data, enabling us to formulate effective strategies to reduce drug use and enhance public safety and health. Mr. Rendo is here today to discuss the collaboration can bring a significant positive impact on our ongoing efforts to combat the opioid crisis in Nevada, and he'll share insights on this technology, its implementation, and the potential outcomes that we can all achieve together. So with that, I'd like to introduce Mr. Rendo and let him take it from here.
Thanks, John. As John said, my name is Ben Rendo. I lead Sturgis in Kansas City, Missouri. Thank you all for sharing your time with me today. I've really been looking forward to speaking with you. I'm going to share my screen real quick. Can everyone see?
Nothing yet.
Still not showing yet. Okay.
Next to the camera and mic button, there's the share button.
Yep.
On mine, it shows here's what I want to share with Teams. It's a Chrome tab, window, entire screen. And then at the bottom, it also says also share tab audio. We can also have the state staff share it. You could just have them go to the next slide. It appears that our state staff does already have the presentation.
If that,
you want to go
if that would be helpful, my IT director actually just stepped out for lunch, and I am deficient at these things, so that would be
okay.
much
No
appreciated.
problem. We have it up on the screen. Can everyone see it? Thumbs up. There we go. Nods. All right, Ben. I believe that you are ready, and you are on page 1. I don't. Just the wastewater drug analysis is what we have.
Good deal. Thank you, David. Sturkis was born out of wastewater testing that my company was doing during the pandemic. So I started our parent company, Mighty Good Solutions, back at the end of 2012. And that company works in health and hygiene products. We manufacture a number of disinfectant wipes, surface wipe, hand wipes, flushable wipes that we sell at big box retail. And during the pandemic, we had helped bring to market a rapid, pretty novel COVID test. And so we had partnered with my colleagues at the laboratory at the University of Missouri. We now have a joint venture where we fund a good deal of R&D that comes out of Mizzou's lab, and we commercialize it. So during the pandemic, we were doing wastewater testing to give our state partners kind of a 10,000 square foot view of what the state of COVID was, state of influenza, state of RSV. And once we kind of brought that up to scale, we wanted to see where we could take it. And so we retooled our process, submitted for new IP, and created Sturkis. So with Sturkis, we can test for the per capita, per person consumption rate of up to 45 different narcotics. So all types of fentanyl, opioids, methamphetamine, heroin, et cetera. And we have a few different ways that we deploy this. We can go to the next slide. So as the last presenter had mentioned, for pregnant women, narcotics abuse was the largest cause of prenatal death. An overall picture of the U.S., narcotics overdoses are the #1 cause per the CDC of injury mortality in the U.S. In the last 25 years, we've seen a 781% increase. Next slide, please. And the state of Nevada has done great work on the ground. City of Henderson has created Risk-It-All with fentanyl, really to help reach kids, let them know the dangers of fentanyl, what it can do to them, that when they are using narcotics, there's a good chance they are going to be laced with fentanyl, and they don't know that. From 2018 to 2022, there's a 46% increase of opioid-related deaths in Clark County alone. Fentanyl, as we all know, 50 times stronger than heroin, 100 times stronger than morphine. Next slide, please. Another narcotic that we test for that has started to make its presence known in the U.S. Started out in Baltimore and Philadelphia, and it started making its way westward as xylazine. So xylazine is a horse tranquilizer that is mixed with fentanyl in order to extend the high. The problem is xylazine induced overdoses are not able to be overcome by naloxone. And so being able to figure out where xylazine usage rate is, how we can help those people, how we can help them get into rehab and rehabilitation and prevent overdoses is crucial. Next slide, please. And that's why we created Sturkis. So Sturkis combines state-of-the-art wastewater analysis with real-time analytics to give health officials a true picture of the state of drug abuse in a targeted area. And here's why this is important. With our platform, we said fentanyl is really one of our primary focuses, but with the ability to test for the per capita, per person drug consumption rates of up to 45 different narcotics. And we do that by collecting at wastewater treatment plants. So if you imagine wastewater treatment plant A serves the surrounding 10 zip codes, we will take a sample with our composite sampler from the incoming sewage pipe once a week. It's a 24-hour composite sample that is then overnighted to my lab. And then within 48 hours, we populate our dashboard. We can show where drug rates are rising, where they're falling. We can help monitor public health campaigns to see what's working in these zip codes where we're starting to see consumption rates go down, what is not working in these zip codes where we're starting to see drug consumption rates go up. I think probably one of the most important things we do is we have AI-enabled analytics, so we can predict out. Right now we're at 2 weeks. We're working to get to about 2 months, but we can predict out in the areas what the fentanyl usage rates will be for these 5 zip codes. We can predict out, given previous data, what the naloxone usage rate is going to be for those same five zip codes in that data. And if those numbers do not match and marry up, i.e. fentanyl usage rate is very high, naloxone use is very low, the state needs to double and triple their naloxone into that area. We do that to prevent overdoses. At the end of the day, if we can't, prevent an overdose, we can't help somebody get better and get into recovery. Our goal with this platform is we want to prevent overdoses, kind of at the macro level at the wastewater treatment plants, and then I'll get into kind of even at the school level, because once the overdoses happen and someone's passed, at that point, the problem is post-acute. We can't save that life, and we're in the business of really making fractional change. If we can help prevent one overdose, each week in the states we're in, we're doing our job, and that's why we're excited for the opportunity to potentially partner with Nevada. If you go to the next slide, please. Could we go to the next slide, please?
Joan or Vanessa? Give them just a second and I'll send a message to see if we can overcome these technical difficulties.
Actually, Dave, if you'll give me 1 second, I can hear my IT manager. He just stepped back in. Okay, there we are. So what we do, kind of 4 major things. Number 1, we discover trends. Go back to the previous one. Thank you. We want to see the seasonality of drug use and distribution. We want to see shipping patterns. We want to see the impact of what the public messaging, what the recovery campaigns are. And it's just like any marketing campaign. We want to see what affects change. And so we can monitor to see, all right, in this portion of the state, we're deploying these 3 marketing campaigns on the dangers of fentanyl, dangers of xylazine, one pill kills, etc. In this area of the state, we're using a different message. All right, in what areas are we driving consumption rates down? And we take that data, get that back to our state partners. So then we kind of bet on the ones that are winning, the ones that are going to help people stop using and get into recovery is what our goal is. We predict outcomes. So as I stated earlier, with our predictive analysis, we can predict out what the per person, per capita drug consumption rates of those narcotics, specifically fentanyl, are going to be in a given area. We can predict out what the naloxone, Narcan usage rate is going to be. And again, in areas that we have a high usage rate of fentanyl, but a low usage rate of naloxone. Those are the areas that we need to help get additional resources deployed there. Emerging drug threats. So we took our technology live in Ohio last year, and a couple things kind of came out on our mapping. Number one, xylazine use has become very widespread. And then the narcotic nitazines are just starting to show up there. A nitazine is a type of opioid that's about 40 to 50 times more powerful than fentanyl. Nitazines were developed in the 50s by Swiss pharmaceutical manufacturers. But when they took it to clinical trial, it was so powerful, unfortunately, it killed most of the participants. So it never made it to market. But precursor and chemical manufacturers in Southeast Asia have realized, since it never made it to market, it hasn't been scheduled in a number of areas as a narcotic in the US. So they're pushing those drugs into our area. And so by checking for nitazines, we can check in real time and see where the emerging new drug trends are, like when xylazine first started making its presence known. And so we can help, develop resources to kind of snuff out those problems before they become widespread. And then lastly, we aid public health. So the ways that we are deploying Sturkis is kind of that 10,000 foot view where we're doing it at wastewater treatment plants. We also have the ability to test at schools, and high schools and colleges. So in the dormitories of a college or at a high school building, they're going to have an outgoing sewage pipe. We set up our equipment at that sewage pipe under the manhole cover, and then we monitor the weekly fentanyl consumption rates. We do that not because we want to be big brother and know what drugs high schoolers are using. We do that because the majority of high school and college students, if they're getting on Snapchat or they're getting on Instagram, they're not looking to score fentanyl. They're buying what they think is an Adderall or they think is a Xanax that's unfortunately laced with fentanyl. And so by monitoring the weekly fentanyl levels, once they spike and hit a trigger point, that triggers a warning that goes out to, at the high school level, all the parents, all the administrators, all the students, letting them know this isn't something that's happening, 3 counties over. This isn't something that's happening at a rival high school. This is something that's happening here in our own backyard right now, and corrective action needs to be taken because an overdose is on the horizon. We go to the next slide, please. And this just kind of shows our macro level data. So we have the ability to tell, number one, if fentanyl showing up is pharmaceutical prescribed or if it's synthetic street level. So if somebody is having back surgery and they're on a fentanyl drip, we back that data out immediately. We are only looking for synthetic street level. We can source the percentages to see if it's carfentanil, if it's parafluorofentanyl, where it's being consumed, how much is being consumed. We have the ability to tell how many doses of naloxone have been given in a given area in the last week. That kind of data is helpful because it lets us know, where does the Narcan need to be distributed at. If it's kind of a piecemeal where it's being distributed evenly throughout the state, certain areas of the state are going to have stronger addiction and more need for Narcan and naloxone to be distributed. And lastly, we have the ability to tell in our testing if fentanyl showing up has been flushed or consumed. So if we're getting a large prevalence of non-metabolized synthetic fentanyl, that's a sign that there's potentially a drug distribution trafficking point there. It's something that further action can be investigated. Next slide, please. And this just goes through kind of a small listing of everything that we test for. So all types of fentanyl, morphine, oxycodone, methadone, xylazine, cocaine, ketamine, etc. Next slide, please. And this shows our portal. So we can share with our partners and our health partners in real time where the narcotic consumption rates are, where they're reaching kind of danger zones, where, excuse me, to create trigger warnings so that when fentanyl consumption rates hit a certain point, in a given grouping of zip codes, that, similar to an Amber Alert, notification goes out to everyone in that area, letting them know, fentanyl rates have spiked and overdoses on the horizon. Now is not the time to be buying pills on Snapchat or Instagram, and for parents to have conversations with their children so we can help prevent overdoses. Next slide, please. And this kind of goes through RIP. So we only need 5 milliliters of a sample from a wastewater treatment plant or from an outgoing sewage pipe at a school or college in order to give that real time per person per capita consumption rates. It only takes us 9 minutes to run a sample at our lab. We have 98% efficiency, so we have PCR level notification on what we're doing. And again, we have the ability to distinguish between pharmaceutical grade versus street grade. We're also working through a relationship we have with the DEA to help detect country of origin, potentially criminal gangs, and tie that back to them. And that is why Sturgis does not have a website. We don't market what we do. We don't broadcast what we do. We're working on the ability to tie back the narcotics to the cartels and other actors that are manufacturing them. And I don't really want them to know who I am or who my employees are. So we don't have a website or really any marketing angle. Next slide, please. And again, knowledge is power. I think we all know that, we have a narcotics consumption challenge in the country. And so, if we don't know where the problem is, where it's most acute, where the people need the most help, we cannot get the resources in there from, an immediate resource like naloxone that helps prevent overdoses and helps save lives, to more longer term, messaging and communications on the dangers of fentanyl, helping people get into rehab and recovery, why that's important, why that can, change a person's life, change their family's life. Like some of the good work the presenters earlier were talking about. This is a life and death thing, and it doesn't just affect the user. It can affect their entire family. And so if we can help those people get into rehabilitation and recovery, and hopefully go on to lead a happier, more fulfilling life, we're doing our job. Next slide, please. And this just goes through some of our program options. Options 1 through 4 go through kind of at that macro level, how many wastewater treatment plants we would monitor the samples on, and then putting into the high schools as well, so we can monitor the fentanyl rates to help stop overdoses. I believe the last slide is just a thank you slide. So again, thank you all for your time today. I'm happy to answer any questions, do anything we can do to be helpful, to help you all and help the people of Nevada.
All right, thank you, Ben. I appreciate it. Thanks for the time. And I do have a question from one of the committee members. Looks like Dr. Wagner, do you have your hand up?
I do, and I have a lot of questions. How would you like, you want me to ask one at a time, Chair, or how would you like to? I have 4 questions.
Yeah, that's fine. I do want to remind the committee members that we have a couple more agenda items to go over, so that if there are questions that will, I don't know, are likely to be better explained through an email or some other type of communication between this committee and Ben's organization, that we can do that. But I will give us a couple of minutes to go through what we can while we're here.
Okay, great. I'll try to start with my easy ones. Carla Wagner, for the record, professor in the UNR School of Public Health. Thank you for that. And I know this is an area of technology that people are super excited about. So I have a few sort of detailed questions and then one bigger picture question. who has access to the data? You're talking a lot about collaborations with DEA, and you said very specifically, like, we're not targeting schools, but on the back end, who can access the data that come out of this system?
So the data is firewalled specifically to the state and who they tell us to give that data to. We do not share this data with the DEA. We do not share this data with law enforcement unless we've been directed by the state to do an active law enforcement investigation. This data is proprietary, belonging to the state. We do not resell it either.
Okay, great. Thank you. You can test kind of at a school level or at a wastewater treatment plant level, and you might have said this and I missed it, but what's the smallest geographical unit that you can hone in on from a wastewater treatment plant?
Sure. So on the wastewater treatment plants, Dr. Wagner, it ties back to how many zip codes that wastewater treatment plant serves. So you're going to have, so like in Ohio, we had some massive ones that served 20 zip codes. And then we had smaller rural ones that were literally serving 2 zip codes. And so that is tied back to whatever zip codes sewage goes to that water plant.
Understood. Great. Thanks. Okay. Question 3, also an easy one. You said there's something like 40 something things that you can test for right now. And you talked a lot about emergence of new synthetics, things we're seeing come onto the market fairly rapidly. How long does it take you to add a new drug to the panel? If we hear next week from people who were using drugs that there's something new on the street, how long would it take your system to add a new drug to your panel to respond to that?
Sure. So nitazines was a good case study for that. That took 2 weeks. We did get samples from the laboratory, run them through our efficacy and output process, and then confirm that we get sample positively for that. So 14 days.
Okay. Okay. Last question, maybe a little bit more longer answer. This is a surveillance system. It's going to provide near real-time data on what's going on in people's bodies and getting into the wastewater treatment. And the promise here is if we can do that kind of real or near-time surveillance, that we can implement action response plans, spike response plans to address emergent phenomena. In your experience of doing this in other states, what does the public health infrastructure need to look like to make good on that promise? Like, what are the things that need to be in place to really make it happen, that when you tell us there's a fentanyl spike in this community, we can actually save lives?
Sure.
Where's it working and what does that look like?
So there's kind of 2 ways that we deploy it. And so they have different answers. So at the macro level, wastewater treatment plants, we have found the most success with, and people that typically work in this field are very passionate about it because they realize that their work saves lives. So we have found the most success with engaged teams from Department of Public Safety, Department of Health and Senior Services, that when we get that data to them, so if we're taking a sample on Monday, it'll be at my lab by Tuesday. We have it uploaded to the dashboard on Thursday, that we can quickly, and by we, I mean our state partners, deploy out messages that, fentanyl rates were X last week, now they're Y. This isn't something that is effective. That messaging is being deployed 30, 45, 60 days later. Like I said, it's similar to an Amber Alert. This is something that when rates spike, corrective action needs to be taken now. And so we are only as good as our state partners in that. But I know that Nevada is very passionate about this issue because it affects all of us. It doesn't care who we are, what we look like, where we're from. Fentanyl affects all of us. And so, as long as we can partner with, proactive teams, that will help us get that message out. And, on the naloxone distribution, when we're getting data on, May 1st that says, all right, July 1st, the fentanyl rates in these 10 zip codes are going to be X, and the naloxone rates are Y. We rely on our state partners. They have got to get the naloxone distributed into those areas. Get messaging out that more is coming into this area, and so that we can help prevent overdoses. Like I said, we can't help somebody, and I know you guys all know this, so I probably sound like a broken record. we cannot help somebody get into rehab if they've already passed. The only way we can do that is if we can help save life during an overdose, and then your team takes over and helps them with the necessary steps to get into treatment. Now at the high school, college dorm level, that notification is also immediate. Would go to the parents, the administrators. At the university level, would go to that dormitory, go to everyone living there. And so, our the ability to get this message out, we can provide the data, we can do the analysis, we can show where it's going. We rely on our partners and people like you all to help us put it into action. Does that answer that question?
Absolutely. Thank you very much.
Thank you, Dr. Wagner. I have Malika Tostin.
Hi, I have two questions. The first one is, how many tests do you run per day per zip code?
So if it's at a wastewater treatment plant, if we're doing the macro testing, we collect one test per week at that wastewater
One test
treatment.
per week? Okay.
Yes, ma'am. And so let's say it's, again, wastewater treatment plant A serves these 5 zip codes.
At least 5.
Yep, we're going to pull the testing on Monday because we're going to want to see everything that had been consumed the prior week. That'll be overnighted to our lab by Tuesday, and you all, depending on who you tell us to grant access to, will have access to that data by Thursday.
All right. And second question, are you also focusing on zip codes and areas where manufacturing could be taking place, where they're disposing of chemicals into our wastewater from manufacturing xylazine, peel press, and stuff like that? Not just only bodily fluid waste, but are you also looking for areas they could be manufacturing?
Yes, ma'am. So one of the ways that we have the ability to deploy this, so we were greenlit in Arkansas by the AG last week. I was in Jackson, Mississippi. We got greenlit on Monday this week. Is more of a law enforcement angle. And so by having the ability to tell if the narcotics have been metabolized and consumed by a person or not, we can work with our law enforcement partners, specifically drug task force. If they come to us and say, all right, in this 10 block radius, we have seen an uptick in EMS getting called out with overdoses. We're seeing a spike in violent crime. We believe there's a trafficking distribution point here. We can send our techs out to sample at the manhole cover level. So at the manhole cover level, in the US, there's a sewage manhole every block to half block. And so we are going to go take samples at every manhole in that 10 block radius. And that will show the presence of unmetabolized, I'll use fentanyl as an example, unmetabolized fentanyl. From there, we can triangulate it back to say the trafficking distribution hub is coming from this half block. It's one of these 3 to 5 houses. Now, I cannot tell you it's 123 Cherry Street, but I can tell you it's one of these 3 to 5 houses on Cherry Street.
That's awesome. Thank you very much.
Yes. And Malika, that's another reason why we don't market. We don't want the bad guys to know that. And so
we absolutely not.
Try to keep our operations kind of close to the vest, for lack of a better term.
Thank you, Malika, and thank you, Ben. I have Dr. Kamyar, after this, we will have any other committee members with questions forwarded to the state staff to get to Ben. The floor is yours, Dr. Kamyar.
Yeah, Farzad here. Ben, thanks so much. Question in regards to the naloxone testing, how are you guys able to differentiate between naloxone that people take that's in part of combination products like Suboxone, right, buprenorphine naloxone, and then naloxone that's administered for opioid overdose reversal?
Sure, that's a great question. So the way that we do it, so my colleague, Dr. Chung Ho Lin, and I can connect him with you if that would be helpful. He developed the process on the naloxone to see the number of metabolites that are attached to it, and then from there calculate the dosage rate. To be perfectly candid, that math is above my head, and so that's why I rely on him for that process. But if it would be helpful, Dr. Kumar, I can connect you with Chung Ho, and he can go into much deeper detail on it.
Yeah, sure. But effectively what I'm hearing is that you guys are able to, let's say we're looking at a zip code, there's 1,500 people who are using Suboxone products, they're excreting naloxone, and then there's 7 people that used in that same zip code naloxone via, let's say, Narcan, right, nasal spray, that you would be able to separate those out and know.
That is correct.
Okay, yeah, that's great. Thanks.
Awesome. Great question, Dr. Camera. Thank you. And Ben and John, thank you for attending today and giving us your presentation. Definitely good information to have moving forward. And I know personally I'd be interested in following up to see what the outcomes have looked like in the states that have already partnered with your organizations to get this moving forward. I know it'll be a topic on the committee's mind as we move forward. So again, appreciate your time and coming here to fill us in on what you got going on.
Absolutely.
Yes, thank you, committee. Thank you for the opportunity for us to be here and present. Thank you. And thank you for all you do.
All right, gentlemen, have a good day. I'm going to move us forward in the agenda. I'm going to move us to agenda item number 6, where we are going to have Vanessa Diaz continue where we left off with Don Yogi with the review of statewide opioid goals. She's going to be presenting the same presentation that we started with last month. And we're going to be picking up with goal 4, provide behavioral health treatment. And I'd like to preface as we move through this that I am relying on the committee members to look at what is currently being funded, what is earmarked for dollars in the budget, and what is not yet funded, to kind of highlight and guide our process of making our recommendations to the director's office. So as we go through here, I'd ask that you make notes to 1, questions and clarification to the state staff, but 2, what interests you that is not being funded, that is currently being funded, and would you would have a recommendation or like to see this committee recommend that we continue funding or increase funding, and then also make notice of the earmarked and internal ongoing sections of this presentation. Vanessa, the floor is yours.
Thank you, David. Hello, everyone. My name is Vanessa, and I'm the Quality Assurance Specialist for the Fund for Resilient Nevada. Today, I'll be continuing to review the goals 4, 5, 6, and 7 of our statewide plan. As I go through the slides, you will notice different colored fonts. Green means it's currently being funded, and I'm just re-reviewing. Yellow means it's internal and ongoing. Purple means they are earmarked dollars in budget, and blue means it is not yet funded. So for goal 4, it's to provide behavioral health treatment, and we break these down through strategy and objectives. The first one will be increase the availability of evidence-based treatments. One of the main things that we're working on right now and currently funding is the OTAC, or the Opioid Technical Assistance Training and Coordination Center. This program began in January of this year. The purpose of this award is to implement a statewide center of excellence that will develop and disseminate evidence-based and research-informed training and offer technical assistance to address opioid use, misuse, abuse, and overdose affecting Nevada communities. So that's one of the things here highlighted in green that we're currently funding. The main focus is improving upon evidence-based substance use disorder and opioid use disorder treatment and recovery, support training, and resources for providers, including subpopulations as well. And these are 2 that we are currently not funding, but we are looking towards. And just to let everybody know right now, we are looking forward to distributing a new NOFO where a lot of people will be able to apply. There's going to be a request for proposals, and it'll be open, and people will be able to apply for this NOFO, and they can let us know which goal in specific they will be applying for. 4.1.2 is to provide a variety of evidence-based and best practices accessible to Nevada's frontier, rural, and urban populations. Right now, we are using evidence-based practices to support mothers, babies, and families impacted by opioid use. This is currently being funded through Empower, a program that you were able to hear from today. We are also continuing to work with tribal communities to meet their needs for prevention, harm reduction, and treatment. This is being done through the Nevada Indian Commission. We are currently funding that. We're funding a tribal opioid coordinator that will help lead coordination as it relates to opioid abatement throughout the state. Next one that we are funding is increasing longer-term and short-term rehabilitation program capacity. This is currently being funded through Living Free Health and Fitness, whom we've also heard from today, as well as Washoe County DAS program. This
Vanessa?
program, yes.
I'm so sorry. This is Elise. Can you remind us what the colors mean? There's a lot on this
Absolutely.
slide and I'm getting confused. I'm so sorry.
Absolutely, no problem. So the color blue, which is the first one you see up there, that one means that it is currently not yet being funded. Green means that it is being funded. Yellow means it is internal and ongoing. And purple means that it is earmarked dollars in our budget. And I'll be sure to give you guys that reminder of the colors as we go through the slides. I know it can get a little bit overwhelming sometimes. So thank you, Elise.
Thank you so much.
Absolutely. I did want to share a little bit about Washoe County DAS STAR program. I'm hoping that this information will help you guys grasp an idea of how we are trying to hit these activities well. So this program focuses on expanding services for criminal justice involved persons with opioid use disorder who are leaving incarceration on probation or pretrial supervision. And some of these services include providing coverage of costs for participants that lose Medicaid eligibility, providing recovery housing, and transportation assistance. We'll move on to our next one. And this is 4.1.3. And this is to expand treatment options for special populations, including adolescents and individuals with co-occurring disorders. We are currently funding expanding treatment options for transition age youth and providing specialty care for adolescents in the child welfare and juvenile justice systems. This is currently being funded through the NIE Communities Coalition, which provides opioid and adverse childhood experiences awareness, education, screening, and linkages for youth aged 18 through 24. We are also funding, currently funding establishing community health worker and peer navigator programs for pregnant and parenting persons with OUD. This is being funded through Empower. Next is the increased parent baby child.
Real quick, Vanessa.
Absolutely.
So as we go through these, I'd ask again the committee members, as we're hearing from Vanessa, she's pointing out the ones that we have funded. Either jump in, unmute yourself and speak up, or raise your hand so that we can see the notification, and then get a break from Vanessa so that you can speak to any section that is blue, as in not yet funded, that you have questions on, or that you would like to see follow up as to how we can look at getting any of those recommendations funded. And I will start with, if we look at the page that we're on currently, and we look at the second one from the bottom, established community health worker peer navigator program for pregnant and parenting persons. So can you help me understand, Vanessa, is that it is being funded, does that mean that there is like more opportunity to have another provider or program or organization have access to those funds, or because they're being funded, that's just that's where we're at with that?
So this is essentially just showing that we are currently funding, so we are hitting one of the activities under this objective, but that's not to say that it's not going to be open for other people to do the exact same work or something similar to hit that same activity. So as I mentioned prior, and I do want to keep everybody, have this in mind for everyone, we are currently going to release a NOFO that's a part of our plan, a NOFO that's going to allow people to apply and we are requesting for proposals, and they'll be able to apply to any of the strategies, any of the goals that they want to hit. So there will be opportunity for them, let's say another organization or program that would want to work on establishing community health workers and the navigator programs and things like that. They'll be able to apply, and we'll have a evaluation committee review these applications. Mhm.
Thank you.
I hope that
Vanessa.
answers.
And do you remember that? Yeah, no, it definitely does. I do remember that last month, Dawn pointed out that there will be a request for proposal process that kind of gets people streamlined into the NOFO so that they can get connected to the funds and then respond by providing services, treatment services, or just supportive services all around for folks that have been impacted by the opioid epidemic. My follow-up is, can you give us or me a bit about what it looks like for an organization that, you know, is already working towards or has plans to enact some type of service, supportive service that aligns with our recommendations? How would they create the, or I don't need like the specifics, but the step-by-step instructions, but how would they, is there, or what is the way, the request for proposal to you that says, this is the program we have, this is the goal that it aligns with, this is the strategy that it's a part of, and how does that organization be considered for the NOFO?
So usually for NOFOs or requests for proposals, and Joan, you can jump in if you are able to explain this a little bit better, but we send out a notification through email. So people will be aware that there's a request for proposals going on. We also will, we are planning to make this readily available on our website so people can go in there and apply through it there, and make it as easy and user-friendly as possible by clicking on or letting us, helping us identify what exactly they're going to be working on. But it should be fairly reminiscent of previous NOVOs that have been sent out as well. Joan, do you have anything to add to that?
No, I think you covered it all. It will go out through listserv. We may be able to send it out through other related agencies' listservs as well, so that there's a broad public awareness of the opportunity.
Okay, sorry about that. I know that was a kind of a broad and wide question, but I appreciate the response, and I have a better understanding now. Thank you.
No problem. I appreciate the question. All right, I'll go on to our next 4.1.4. So this is to expand and maximize capacity of current services and increase workforce. Some of these activities include promoting healthcare profession career tracks in high school, and evaluating provider enrollment process to ensure it is not a deterrent for providers. So this in specific, I want to remind everyone that yellow means that this is internal and ongoing. So these are things that we are currently working on and building a process for. Next slide, 4.2.1. It's to increase access to evidence-based treatment and expand treatment funding options. So we have earmarked dollars for FRN to utilize funding for state's share for the 1115 SUD waiver, room and board, and uncompensated care. I'm going to move on to the next slide. If anybody has any questions, please let me know. 4.3.1 is to increase availability of and access to MOUD, increase the volume of waivered prescribers of medications for opioid use disorder, providing treatment in rural and underserved areas. So at the current moment, we are funding this activity, implementing a plan for expansion of mobile MOUD treatment for rural and frontier communities. This is being funded through CASAT, in which 3 mobile recovery units were purchased and will be distributed to 3 qualified organizations. For goal and for objective 4.3.2, which is to increase access to MOUD, we are currently funding this activity, initiate buprenorphine in the emergency department and during days, as well as expand access to MOUD treatment for youth in primary care and behavioral health settings. These 2 activities are both being funded through Quest Counseling. Quest provides immediate resources and care to youth through age 24 after their admittance to area hospitals for opioid-related misuse or overdose, as well as offers a continuum of care following hospital discharge. Strategy 4.3 is to increase availability of and access to MOUD. And we are increasing provider proficiency in treatment with MOUD activitities. The activities that are doing this are creating a provider forum for treatment and other resource sharing. We are doing this through the OTAC that I mentioned earlier. Moving on. 4.4 is increased treatment for neonatal abstinence syndrome. We've heard from our awesome partner, Empower, and they are helping us hit these activities and doing a very incredible job at doing so. They're offering parenting programs and home visits for at-risk pregnant women, and they're also helping us hit this activity as well. Continue to monitor and expand ASTA programs for neonatal abstinence syndrome, with special attention to preventing health disparities. We're on to strategy 5, and I'm going to give you all a reminder again, since we're seeing a few colors on here. Green means that it is currently being funded. Yellow means it's internal and ongoing. Purple means they are earmarked dollars, and blue means it is not yet funded. Okay, so for this, we are addressing social determinants of health, incorporating screening for standard social determinants of health needs as routine intake procedure for all services. These are things that we're building out, and we have our awesome person from the Office of Analytics who is helping us build this out internally, and it is an ongoing process. We are also establishing policies and funding to support evidence-based recovery housing, and through Washoe County DAS STAR program, which I mentioned earlier, as well as Living Free Health and Fitness, whom we were able to hear from today, we are hitting these activities of providing tenancy supports for individuals to maintain housing through the recovery process, as well as develop sober and affordable housing resources through partnerships.
I have a question about the youth
Absolutely.
housing. Do you guys, do we plan on doing a NOFO to improve youth housing?
So again, we actually just decided to fund a few programs focused on youth. But going forward, we are also opening up the NOFO and request for proposals where they will be able to apply. If there's a program or organization out there, they will be able to apply for youth housing. So that is everything with our new strategy that we're thinking of opening it all up, and they can hit these goals and really let us know and put their best foot forward with letting us know that they're going to apply for these funds. I hope that answers your question.
Before you continue, I just
Yes.
wanted to say that I think that's a really good question. So we look at 5.1.2 access to housing activities. We have blue, which means not yet funded, develop housing and recovery supports for homeless youth with OUD. So this is the opportunity for an organization within Nevada to reach out and say, we have a current program that is meeting this need, or we plan on developing this program, and then they respond to the NOFO, and then once they meet all the expectation of the funding, then they will be funded. Does that sound accurate?
It sounds accurate, but I will say this, that only because they apply does not mean they will immediately be funded or chosen to be funded, right? We have an evaluation committee that we're going to be choosing people and different experts in the field to be able to review these applications and let us know whether this program is sustainable and other different things that are necessary in order to say yes to an organization and go ahead and funding them. But I do, and we all agree that this is an incredibly important thing to fund, activity to fund.
Okay, perfect. And I this is a good time for me, actually. I wanted to just let it be known that I did change positions recently, and I work in the community on one of the residential treatment centers. And my next question, just to be clear about that, is about the 1115 waiver for room and board. That's a purple one earmarked for budget dollars. my question is, if a place in the south and the north were going for the same funds, how would they determine who, and then they both qualify or whatever, how would the state determine which one is funded? Like, what's the priority there? I know this is messy and I'm getting into the weeds here a little bit, but just looking for a little bit of understanding as I step into this world.
Joan, you can let me know if I'm wrong on this, and I would like to make sure that Dawn has an opinion on this. I would prefer that, but I will say that it's not an either or situation. We don't look at funding on either or. It's never going to be, if we fund this program in the north, we can't fund it in the south. So it really has to do on how strong their application was, the needs, and the goals that they're going to be applying for. So obviously, if we have some applications coming in and there's going to be we're missing applications in one, or how would I explain this? Probably I would most likely have Dawn answer this well, but I will be able to say this, that it's not an either or situation. So that's not
that I think clears it up for me right away. Like, it's not just one or the other. There's a thorough and due process to determine how the funding gets out.
Absolutely. Okay,
thank you.
Awesome. We'll go ahead and move on to our next one. Strategy 5.1 is address social determinants of health. So one of the activities under this, specifically these 5.1.3, is addressing employment supports. As we heard from Living Free Health and Fitness, they are helping develop employment supports for those in treatment and in recovery through their gym and through their cafe. So we're able to do that right now, and say that we're currently funding this activity. We're also currently funding addressing transportation needs as a social determinant of health, and Washoe County, DAS Star, as well as Carson Community Counseling Center are doing a great job at doing this. Carson Community Counseling Center provides high-intensity residential treatment for people within the criminal justice and public safety systems impacted by their opioid use. So they are also helping provide transportation services as well as the DAS program. We're on to strategy 6. This is to promote safe response to opioid use in community. Objective 6.1.1 is to ensure laws and law enforcement agencies do not deter interventions for people in need of harm reduction interventions. Right now, we have an internal and ongoing process going with ensuring state laws do not prevent harm reduction efforts. Strategy 6.
Dr. Wagner with her hand up. Dr. Wagner?
Absolutely, Dr. Wagner.
Thank you. Quick question about that one. The train law enforcement on laws to increase appropriate enforcement. Last summer, in cooperation with CASAT and other folks at the state, including Attorney General's office and Terry Kern, we brought the SHIELD training to Southern Nevada to do a train the trainer that was supposed to disseminate and propagate throughout law enforcement across the state. Is there an opportunity here to fund that dissemination through this strategy? And if so, how would people take access or take advantage of that?
Great question. I can get back with you to that question. If you can email that to me, I think I would be able to better respond there. But I do believe that this is something that can be up for discussion.
For sure, and that's the kind of point out that I'm looking for, is that I remember hearing about the SHIELD training, and again, the plan to get it all the way through, because we have trained the trainers, we have more trainers now. And I think that Dawn might have an update on this for us. And if not, then at least we can get some guidance on how to promote the local, the different law enforcement agencies to get notified to submit for the NOFO to be able to increase this training across the state.
Absolutely. Thank you so much for your question and bringing that to our attention. Okay. Strategy 6.2, to prevent overdose after release from jails and prisons. increase access to quality care for justice-involved individuals and activities. Again, I want to remind everyone that green means that it's currently being funded. And yellow means that it is internal and ongoing. So right now we are providing MAT in all adult correctional and juvenile justice facilities through Carson City Community Counseling Center. We are also connecting people in 6.2.2 to support individuals. We're connecting people leaving jails and prisons to post-release treatment. Yes, Dr. Wagner?
Sorry, hi, Carla Wagner. Just clarifying point on that first bullet point. The recommendation is to provide MAT in all correctional facilities. Is Carson City Community Counseling Center providing MAT in all correctional facilities? Or like what, can you give us more detail on the scope of that?
Sure, absolutely. Let me, just so that I do not get information mixed up. I want to make sure that I'm actually able to pull up the scope of work, and maybe you guys would be interested in taking a look at it as well. Joan, do you happen to have that answer at the top of your mind? I'm trying to get
Yes.
through. Okay.
Carson City is currently not providing in all correctional facilities. They are providing MAT in Carson City, Story, and Douglas counties. So it's the beginning of it. We are funding the activity, but it is in a selected market. So this one is another one where there's room for more agencies to hop on in the next MILFO.
Okay, thank you. Carla Wagner again, just another question, Joan, if you know the answer. I don't know if you do, but I know that the Washoe County Detention Facility has a fairly robust and comprehensive program. Are we funding that? Is this fund funding them?
I don't believe so. I think that's done through the county.
So I want to restate what you just said. There is room to grow here, right? We know that there is MOUD in some correctional facilities, but the work's not done.
Correct. And actually there is another program, I think, that Bill Teal
Yes.
presented last month. And he is on a project that is doing pilot programs in Lander, and I think the other one is in Waldock County, starting MOUD.
Yes. Okay. We're on to our last strategy. Goal 7 is to provide high quality and robust data and accessible timely reporting. So objective 7.1.1 is to improve the quality of toxology data. Some of these activities have not yet been funded, but again, this is an area that will be open for our next NOFA application. 7.1.2 is to improve and standardize surveillance reporting. Internally and ongoing, we have standardizing reporting and query code logic across reporting agencies, as well as established minimum data set for suspected and actual overdose for use in all agencies, including demographic characteristics. Yes, I do see a participant with their hand up. Please go ahead.
Thank you. This is Elise for the record. So just one thing I wanted to note, I guess just get on the record, since we heard a presentation today about improving our ability to collect more data through wastewater surveillance. One thing I want to make sure the state thinks about in funding that kind of surveillance and wastewater testing is that ensuring that, to Dr. Wagner's point in her question, is that there is a supported public health infrastructure to respond. What I heard the presenters say was that they use their wastewater testing to deploy public safety, which would not be overdose prevention. That would be an increase in like a law enforcement presence, which is not necessarily what we need to reduce overdose deaths. So the need for upstream surveillance is very important, but ensuring that the state has the infrastructure in place to have meaningful overdose reduction
response with the data is also.
Absolutely. I will say that I think the earlier presentation, you let us know that the state has full ability to whether to get law enforcement involved or not in some of the data that they're taking as well. And I absolutely agree that that infrastructure is absolutely needed. And currently we are internally and ongoing building these things out. So I appreciate the question and the comment on this. 7.2 is to increase availability of data for rapid response to opioid trends. And this is to increase breadth of data collected. We're currently funding this through collecting data from the Poison Control Hotline through DPBH Public Health Preparedness Program. Objective 7.2.2 is to ensure data is shared across agencies and providers. Some of these activities include implementing the All Payer Claims database. That is something that we are currently funding through the Division of Healthcare, Financing, and Policy. We are also currently funding creating an automated program interface connection to emergency medical services and EMS image trend through DPBH Emergency Medical Services.
I will say on this page, this is David Sanchez. I will say on this page that 7.2.1 include demographics and methadone in the state prescription drug monitoring program, and 7.2.2 increase health information exchange, data sharing, and utilization when prescribing opioids are two that are on my radar as far as when it comes to prescribers that prescribe Suboxone for people in treatment, to help them navigate and regulate to make sure that the client that they're serving isn't receiving opioids by someone else. My understanding that is it's a bit of a messy process, but I could just be confused and not really informed. Does anybody have anything that they can add to that? And then also, is this something that the committee is interested in following up on to determine if there is a way for the ACRN to make a recommendation to fund these issues?
Great question and comment, David, Chairman David. But I think this is something that I'll probably have Dawn speak to at the current moment. I'm not too sure as well.
As long as we can get it on the radar, I appreciate it.
Absolutely. Strategy 7.2 is to increase availability of data for rapid response to opioid trends. The objective, provide immediate access to critical opioid-related data. Some of these activities include providing access to real-time substance use disorder, opioid use disorder reports from various systems. Right now, we currently have EHR in place. And we are currently funding connecting public safety and local overdose spike monitoring agencies through the Nevada Division of Emergency Management, as well as the OTAC. Other than that, absolutely.
Thank you. I'm also interested, which the yellow one here, internal ongoing, I think answers the question that I had about the previous slide. But if we look at the second bullet point here, facilitate prompt bad batch communications, I'm interested again in putting it on the board of things that at least myself as a committee member are interested in, to find out what it looks like to help fund or provide support to some type of bad batch communications and what that looks like moving forward from here.
Sure. Again, I think this will be an opportunity for some organizations to be able to apply in our NOFO and request for proposals. Mm-hmm.
All right. I think that is the end for Vanessa. Does anybody have any questions or comments or concerns? Did they notice anything that stuck out to them as far as priorities for recommendations for our not proposal, what is it called that goes to the governor's office this week, or not this week, this next coming June? It's the board's recommendations. I forget the name. Dr. Camiar, take over for me.
Hey, yeah, sorry. This is just a general question in regards to the goals, like strategies, objectives that I'm seeing. I'm trying to do sort of a cross between what we had in that statewide plan, which was generated based off of like all those recommendations, I think that we had gone through with associated sort of impact scores or priority scores, or I can see what we called them. And then I'm going through, and I think I had brought this up before, that I thought some of the items were incorrectly scored because of the target legislative score being zeroed out for items that were specifically targeting those legislative items. And then looking into it right now, I see that it looks like there's only 3 things that were chosen as priorities: prevention of overdose, addressing disparities in access to healthcare, and prevention of substance use among youth. I'm not exactly sure why or where that happened, that only those 3 gave priority to items. Whereas I remember that it was much broader, like there was 10 things that it needed to address: persons and families impacted by the use of opioids, substance use disorder prevention coalitions, et cetera, et cetera, et cetera. But anyhow, I'm just a little concerned, not concerned, but just, when we're looking at prioritizing what's happening, and if we potentially have, and I'm saying this because I'm not seeing a lot, well, I'm saying this because pregnancy is a huge deal. It's a huge deal when it comes to impact scores. We have multiple, like when you look on the 10 sort of items, right? We talk about, when we're prioritizing, prevention of overdoses. You treat a pregnant patient, you prevented potentially 2+ overdoses. Addressing disparities in access to healthcare. Well, I can tell you, pregnant folks have a heck of a time getting access to healthcare. And then prevention of substance use among youth. So we know that treatment is generational and has effects on the kiddos line. Yeah, right. We're talking ACEs and genetic predispositions. So pregnancy treatment hits all three of those. And yeah, so something to take note of for future purposes. Thanks.
Thank you, Dr. Camiar.
Yes, thank you. I was going to say, Dr. Camiar, I think on the same page with you when it comes to at the time when we were getting the recommendations prioritized, they seemed a little wonky to me as well. But I think we're at the point today that as we look at the presentation by Dawn and Vanessa, I'm really counting on the committee members to highlight these ones that we've gone over and that have been prioritized, with some consideration to what their priority was previously, but to have the committee members advocate for the gaps and the lacks that we're seeing in funding today and moving forward, so that our I just lost the word again. Our recommendations to the state and the director's office, when they make the decision, they show that these are the things that are a priority to us today. So we saw there were a couple of programs that were working towards increased parent, baby, child treatment options, including recovery housing. That remains high on our list of priorities, and that Dr. Camiar would be one to advocate for that one and to speak to it, to say, I would like to see this continue being funded or additional funding, and then each committee member will have the things that are either being funded and need additional funding, not being funded, or are not even on the radar. That's why I asked the questions about the ones that I saw. So good point to your comment, Dr. Camiar, but let's continue it going moving forward so that we get them, that your concerns, your area of expertise listed as high needs recommendations by our committee.
Absolutely. Thank you so much, Chairman David. I appreciate that. That is extremely important for us as well. Your recommendations helped us fund some incredible programs, and it's truly making a difference in our communities and our state as a whole, and we want to continue doing that work. We are proud of our programs and excited to see the outcomes of your recommendations. But yes, absolutely. It's extremely important, and I appreciate the perspective that you're having this time around, as well, of looking at what is not currently being funded or what needs to be continued to be funded. It is truly important and really does guide us.
Okay. I thank you, Vanessa, and thank you, committee members, for participating in the last bits that we'll have on where our opioid goals currently are and what it is we're going to list as a priority moving forward. At this time, I'm going to move us forward into the agenda. We're getting kind of short on time. We're going to move to agenda item number 7. Elise, you have a question?
Yes, a very quick question, just to clarify the last conversation. So what I heard was Dr. Kamiar ask, like, so the pregnant, response for pregnant people didn't make it into the rating system, and there wasn't a lot of transparency around the score. So, like, we're trying to understand that. And then, so how, and I know we're having the conversation today, but like, how are the recommendations going to be, or the ranking going, the conversation that we're having today? Will there be a new report? Will there be a new scoring? Like, how are changing priorities or changing ranking being captured?
Good question, and you broke up a little bit for me there, but without Dawn here, the best I have, and maybe Vanessa has it, but the best I have is that it won't be done the same way that it was done before, in that we'll have an outside agency help us prioritize them. We are, in the next 2 meetings, we are going to prioritize what is important to us based off of these things that we've just gone over. And we'll also include in that group of things that are important to us, the surge report, and that'll go into our report to the director's office, and we will be listing them as priorities, like in a priority order. We might not even get to a priority order because of how much time we have. We might just say, here's the lump of things that we have as recommendations moving forward. Does that clarify, or am I missing it a little bit?
No, I think so. Thank you.
No, Oops,
Sorry,
so sorry, David. I did want to let you guys know that there is updates that happen frequently to the statewide plan. So as we move forward with your recommendations and priorities, that will be taken into consideration as we update the new statewide plan.
Yes, so I was just going to say that I get where there's confusion or like a lack of like clarity on the process that we used in the beginning and where we're at today. And I think that mostly due to like time constraints, we will be the people guiding the importance of our recommendations. So I really ask the committee members, the things that they see that are not being funded or that are being funded, and we need to, or we have a desire to see them be funded more because of the impact that they're having on our communities, and as far as treatment, supportive networks, whatever it may be, I'd like to hear from the committee members so that we can say, this is on the board, this is on the board of things that are important. Let's put it into our recommendations. Anybody for it, anybody against it, why either way, and then we move forward. Makes sense? Doesn't make sense? Thumbs up, head nods. Got a couple of them. Okay. I'm going to push us forward into agenda item number 7, which is for possible action, but it looks like we're just going to review because we're out of time. I got a thumbs up there. Thank you. Review. We're not going to approve, prioritize the surge working group funding recommendations, but we are going to look at them, review them, consider them, and then I ask again that you highlight, make a note of, make it clear, maybe not in this meeting, but in the meeting that is coming next and the one after that, that you would like to see these recommendations from the surge pushed forward as part of our recommendations to the director's office. I don't have access. My state team, Vanessa or Joan, have the surge recommendations to pull up? Oh, maybe I do. Oh, no, wait, do I? Oh, no, I don't. Oh, they're up. There we go. Okay, so I'm going to work with this one, and I'm going to be relying on Joan and Dawn to help me clarify if there are questions or confusion on my end. But as we move forward, this came from the surge. They broke out into subcommittees, and each one did research and discussion on what it is that they would like to see. And my understanding was that they were more going to be policy based, but either way, this is what came out. So we're going to take what we can and leave the rest. So if there's something on here, which you don't have to make a decision today, but I would ask that you make it clear by making a note, you can take it forward at our next 2 meetings. The first surge recommendation is to support harm reduction through making a recommendation to utilize opioid settlement dollars. Dr. Wagner, go ahead.
Hi, sorry, Carla Wagner. I didn't mean to interrupt, but I have a process question because we started this process last meeting, and then me and maybe some others didn't do our homework, and we were asked to rank through email. So is this now, are you telling us how we ranked these things, or what is our job right now, given what we did before?
Yeah, no, that's a good point. I mean, I did mine so long ago that I forgot that we did that until right now when you brought it up. So I'm glad that you brought it up. Hopefully we had more participation, but I was rolling with the assumption that we did, and they needed to be read out loud and asked for clarification questions and whatnot to the whole committee as everybody that's here. Joan, did we get more feedback, or do we have that? What is it called? It's called a little poll that we did as a committee on these recommendations. Do we have that information available?
Yes, more people contributed to the poll, and the order of these is based on the results of the poll.
So this right now is current and updated to what we found in the poll. Is that correct?
It's correct.
Nice. So there we go. That answers the question, correct, Dr. Wagner?
Hi, Carla Wagner. Yes. So yes, but I'm just going to say back. So what you were doing right now is just showing us the results from that poll where we prioritized these recommendations from the surge, and you were not asking us to do anything because we're out of time.
Exactly. Joan, does that check out?
Yes, that does sound correct. Thank you, Dr. Wagner.
Thank you. Okay, so this first page are 3 that were prioritized by this group, or the members that participated in the poll. And again, we don't have to take them all. We don't have to take any of them. But I'm asking committee members, which one of these, or out of all of them, if you want to take them all, then when we go through this next month, because next month it's time. Next month it's time to go through goals 1 through 7 on our statewide opioid goals, and go over the surge recommendations and say, out of goal 1, we choose 1, 2, and 3. Out of goal 4, we choose 5, 6, and 7. Out of surge recommendations, we choose 1, 8, 9, and 12. So keep that in mind. I will go through this briefly, and then we will move to concluding this meeting or after doing the public comment number 2. So the first one, make a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline level of identification and overdose reversal medication for the next 10 years. And I think this has to do with supporting the naloxone saturation plan mostly, because there are issues with sustaining having what we need as a state for naloxone distribution to get it into the right hands of the right people that are needing it. And then also it's just a struggle for communities to have what they need to be able to give it out efficiently. So I see this one as personally an important one that I would be interested in moving forward. Does anybody else have anything to say about this first one? And again, you can either unmute yourself or raise your hand via Teams. I'm going to move forward to the next one. This next one is, this is a good one. Evaluate current availability and readiness to provide comprehensive behavioral health services to include, but not limited to, screening, assessment, treatment, recovery, and transition reentry into local in local and state carceral facilities. So this one I think has to do with the 1115 waiver, which again, my experience is that the folks coming out of correctional facilities, one of the bigger things that make it a challenge are safe or healthy living environments where they can like continue or get supportive housing treatment. And there is a way to get that done through this waiver, but I think the waiver has some issues around it. I'm not sure what they are, but this was a priority of the committee members that went through the poll. Does anybody have anything to say about this one? All right, I'm gonna move this forward. This one was kind of confusing to me. It's a recommend to DHHS and DPBH that the Bureau of Behavioral Health and Wellness and Prevention to double the amount of investment in SAPTA primary prevention programming, which was really confusing. I remember we had a comment from, was it Jamie? I'm not sure who it was, but what does this look like? It was rated third by the folks on the committee that went through the poll, but this one kind of stands out to me as one that I would not be personally bringing forward to the recommendations as part of our report to the director's office. Can we go to the next page, or does anybody have anything to say about it? There we go. I got Elise.
Yes, and I apologize. Charter's here. They turned off my internet, so I'm on my phone over Wi-Fi. So I think the question and why this was confusing was for us is the ACRN, we have our own dollars that we're recommending on, but SAPTA is that is block grant funding. It comes from the state. So I think that might be the question or the confusion.
Right, which that's why I kind of went right over it, is it really doesn't have anything to do with us. Can we make a recommendation to double the amount of investment in SAPTA? I don't know if we have that. I don't know if it holds much weight, or maybe I'm just confused on the wording, but I'm with you on that one, Elise. So I don't know. I kind of feel like I'm just reading these out and we've already gone over them. I guess I'll pivot here and I'll ask committee members. Those of you who have been part of this poll have kind of highlighted what is important to you. Can we hear from any committee members that plan on advocating for one of these recommendations to be a part of our report to the director's office as we move into next month's meeting to lock these things down? Dr. Wagner.
Hi, Carla Wagner. I remember there being more than 3. Is this it?
Oh,
Or
no,
there's
if we
more?
go to the next page, it's like next page. So there's like 5 more pages, I think.
Okay, so I think, if I may, I think it's useful for us as a committee to see the priority ranking. But I guess I'm not clear on whether you're asking for more action than that. Like, I think.
No, yeah. So
Okay.
I originally, according to this agenda, we were supposed to take a vote and say, we approve some of them. We approve the first 3, we approve the last 3, whatever it was, but we're not going to do that today because we're out of time. So what I am asking, anything on here that's important to you, make a note of it. When we go through the recommendations next month and the month after, and we say, here we go, this is the time that we're going to include these on our report. I need the committee members that find any of these as a priority, as something important to them that they would see part of our recommendations, to say, hey, surge recommendation number 5, that was huge to me. I need to see that. I would like to see that one. And then we have a discussion about it. And then after that, we approve to add it into our recommendations. Dr. Cameron.
Hey, Farzad here. Okay, so when I was looking at the list that we ranked, I believe there was 10 recommendations. What seemed to be missing for me was things surrounding actual treatment. So then I went to the Surge website and started to dig around because it's hard to get through there because the documents attached to their meetings aren't titled. You have to click and read what it is. But I'm looking through their 2023 recommendations and I'm basically seeing 20 of them. And so, and that's where I'm starting to see stuff about treatment that I didn't see in the rank list that we ranked. And my guess is if those 10 match the 10 that we're seeing on these slides, it wouldn't be there.
I'm not sure if that's exactly. Go
So
ahead,
like for example, table 2, full recommendation. Number 2 is expand access to MAT and recovery support for SUD, limit barriers to individuals seeking treatment regardless of the ability to pay, and encourage the use of hub and spoke systems, et cetera, et cetera, et cetera. It's about MAT. And then on the list that we ranked, I don't see that one.
So I believe what it is, and Joan, clarify if I'm incorrect. 2023's recommendations from the surge were done and put out. After that, they did work to like refine or better highlight what it is that after their recommendations went out through research and conversation, what it is that was missing, needs to be increased, or better verbiage of how to promote those recommendations. Joan, does that check out?
What we included in the surge recommendations are the recommendations that they were wanted to tap FRN funding for, or they in their recommendations they viewed the FRN as the source for funding. So yes, there were other things on their recommendations, but those had other funding sources associated with it.
Got it. Okay, thank you, Joan, for that clarification. Appreciate it.
Yes, big thank you, Joan. All right, I'm going to cut us off right here. I'm going to move us forward. We should table this. We'll come back to it. Again, like I was talking about, this will be part of something that we will go over as we finalize our report, which needs to be done in 2 months. 2 meetings, we will need to finalize our report and get it to the director's office. That'll include this committee coming to an agreement on recommendations that we will be moving forward for funding. At this time, I'm going to close agenda item number 7. I'm going to open agenda item number 8, and I'm going to get us to public comment number 2. Public comment will be taken, and my apologies, committee, for not being more on top of this and managing the time better, but we'll be a couple minutes over as I open this up. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment, telephonically dial 775-321-6111. When prompted to provide the meeting ID, enter 846-416-202 pound. Please note that if you're joining by phone, press *6 to mute and unmute, and press *5 to raise your hand. In consideration of others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on a matter discussed under this item until the matter is included on an agenda item on which action may be taken. Do we have anybody available or interested in giving public comment as part of public comment number 2? State team, do you see anybody? I'm not seeing anybody on my end.
No, there's no one indicating that they want to take part in public comment.
All right, thank you, Joan. I'm gonna give it another second so that I don't miss anybody. All right, anyone interested or available in public comment number 2, now is your time, or I'll be moving forward in the agenda. All right, public comment number 2 is now closed, and we will be moving to agenda item number 9, which is adjournment. Thank you for attending this meeting and showing up and being a part of it. Thank you to our presenters for coming and give us some insight into what it is that's been going on that's currently being funded as a result of our recommendations. And committee members, again, next 2 meetings are going to be big. We'll be coming to an agreement on what it is our recommendations as part of our report to the director's office will be. So I really would appreciate it if you could make time to be present at these next 2 meetings, because it's going to be the bulk of our work for this 2 years of service. Thank you again for everyone that attended, and I will see you in May. This meeting is now adjourned.